The following podcast is part of a certified educational activity titled A Roadmap for Modern RCC Care, Navigating Personalized Treatment Selection and Sequencing. Access the entire activity and complete the post-test at peerview.com/GXM860. Downloadable slides and practice aids are also available.
Welcome, everybody. Thanks so much for joining us. I know there's many places you could be here at ASCO 2024, and we're delighted you've chosen to spend the evening with us here at PeerView. My name is Monty Pallett. I'm a medical oncologist at City of Hope. I'm really thrilled to have an outstanding panel of guests / friends / mentors. Tian Zhang, who's at UT Southwestern, running a brilliant program there in GU cancers, and Nizar Tanir, who I've leaned on for many years for advice along the way, clinical, in career, and in life, frankly. And he's at MD Anderson, of course, and runs the kidney cancer program. There really needs no introduction. He's run so many pivotal trials through the course of his career. Tonight, we're going to really be updating you with the latest and greatest in kidney cancer. We have a couple of goals for today, but here we're going to try to bolster your knowledge of safety data and efficacy data for emerging treatment options for kidney cancer. We're really going to talk about our own personalized approach to care. And finally, provide you with some strategies to manage toxicities as you encounter some of the new agents that we're using for the disease. I wanted to give out a huge shout out to KC Cure. KC Cure is a group that Nizar and Tian and I are well familiar with, work with very often, and they do a really phenomenal job of really giving patients with kidney cancer a voice. They do lots of surveys that help inform our clinical practice, frankly. And in addition to that, there's tons of outreach that they provide to patients in terms of helping them either manage their current condition, identify clinical trials. So if you are a provider and if you want to refer your patients to a good, validated resource, I think KC Cure is one that I would certainly refer them to. And we're going to kick things off with my dear friend, Dr. Tanir, who is a professor in the Department of GU Medical Oncology at the University of Texas MD Anderson Cancer Center. Dr. Tanir?
Thank you, Monty, for the kind introduction, and thank you all for coming. Again, I'd like to echo your statement, thanking PeerView and KC Cure for the opportunity to speak here. It's always a pleasure to be with you on stage, and Tian, and I look forward to a really dynamic, interactive, and very hopefully informative session. So, talking about first line, I think, you've seen this timeline for FDA approvals of RCC therapies. There are many more agents on this slide, but chose to focus on the ones that are in first line, since my presentation is about first line therapy. Just to remind you, there are 5 classes of FDA-approved agents for RCC. The old cytokines, and that's high-dose IL-2, was approved in 1992. And then we have, after that, a series of several VEGFR TKIs. You see here several of those, sorafenib and then sunitinib, then mTOR inhibitors, and then, obviously the era of checkpoint inhibitors opened and is with us here in first line with 2 validated pathways, CTLA-4 and PD-1, PD-L1. And of course, we'll talk about those combinations and the regimens that brought these approvals. First in 2018 with Nivo-Ipi, then in 2019, 2 regimens. But I think, the ones that I will be focusing on are the ones that really showed OS benefit for the combinations over sunitinib, which was used in all those 4 regimens that I will review with you. Sunitinib was the control arm. And of course, there is the latest one, the belzutifan, which my colleague Tian Zhang will speak about, which is a HIF-2 alpha inhibitor. And so it's exciting time. The field is moving forward, and we're really hoping for our patients to really have a chance at durable responses and long-term survival. So I'm going to review again the 4 regimens that are approved in first line that showed survival advantage over sunitinib, starting chronologically with the one that was launched first, and this is CheckMate 214. And, I'm going to focus on the latest results from the latest follow-ups that were obviously either presented or published for these 4 regimens. So I presented at ASCO GU back in January the updated long-term 8 years median follow-up for CheckMate 214. Again, to remind you, this was nivo-ipi versus sunitinib, and the 3 co-primary endpoints for the trial was OS, PFS, and ORR in intermediate poor risk. And this is what I'm going to show you now, the results for intent to treat as well intermediate poor risk and favorable risk, which was a exploratory group here. And what you see here is, the panel here. This is the Kaplan-Meier curves for OS for the 2 treatments, and then nivo-ipi is the top one here, and then this is sunitinib. And then you can see here the median here OS for the nivo-ipi arm was around 54 months, and versus 38 months for sunitinib, and this is about 10% improvement in OS for the combination at 90 months here. And then this is for the intermediate poor risk, this Kaplan-Meier curves plot here. And then there is here also an 11% improvement in OS, in probability of OS at 90 months. And then you can see here the median OS for the 2 treatment arms. And then for favorable, I think, from the initial primary analysis, the favorable risk initially, there was inconclusive evidence, and there's still inconclusive evidence. However, there is a trend towards improvement in OS, even for the favorable risk in favor of nivo-ipi, with 9% improvement in OS over sunitinib at 90 months. And you can see here in green, these blocks, the hazard ratio has remained almost similar from primary analysis back in 2017 to the 2024. Here, the hazard ratio for the intent to treat 0.72, and for the intermediate poor risk 0.69, and for the favorable risk, the hazard ratio is 0.82, an improvement over 8 years from 1.45 before. So this is the PFS. Again, it was a co-primary endpoint for intermediate risk poor risk, and you can see on top is the ITT, and you can see here the median PFS and the hazard ratio 0.88. And then here you can see that there is a plateau for PFS for intermediate poor risk, with about a quarter of the patients alive and progression-free. So there is hope that here, for nivo-ipi compared to sunitinib, we are seeing a shoulder or a plateau, a tail at the end of the curve for intermediate poor risk. Now, for favorable, again, if you're looking at ORR and PFS, sunitinib is going to produce better results, as shown here for the favorable risk. Now, this is the responses, again, improvement, and you can see here in red, what is important for our patients is to achieve a CR, and here you are versus sunitinib, 12 versus 3, 12 versus 3, and even in the favorable risk, you have almost doubling, 13 versus 6 for CR, comparing nivo-ipi versus sunitinib. And one thing we'll look at will be the progressive disease rate, and it is here 18% for the intent to treat for nivo-ipi versus 14% for sunitinib, 19% for intermediate poor risk versus 17%, and then 12% versus 5%. This is one of the endpoints that could be, and we can discuss that. It will be important for us when we look at, selecting therapy for our patients. We would like to also, look at CR, durability of the CR, durability of response, OS over time, but also progressive disease rate can factor in our debate or selection for first-line therapy. So the median duration of response for the ITT was 76 months with nivo-ipi versus 25 months with sunitinib. And for that intermediate poor risk, again, the primary population, the median duration of response with nivo-ipi was 83 months versus 20 months with sunitinib. So quadruple the median duration of response in favor of nivo-ipi versus sunitinib. And even for favorable risk, over time now, again with 8 years median follow-up, the median duration of response is almost double, 61.5 months with nivo-ipi versus 33 months for sunitinib. So looking now at the, we're going to go over the 3 IO TKI regimens. Again, chronologically, KEYNOTE-426 was the first IO TKI with pembrolizumab plus axitinib. Again, there were 2 co-primary endpoints for that study, PFS and OS for intent to treat. And then this is the latest follow-up with 5 years median follow-up, 67 months. Here, this is the Kaplan-Meier curve for PFS. You can see a nice separation from the beginning when it looks like there is some plateauing here in favor of the combination of pembrolizumab plus axitinib versus sunitinib. And you can see the hazard ratio for PFS, or, with median follow-up of 67 months, 0.69. However, when the story comes to OS, over time, it looks like these two curves are coming together. The median, you can see here the median OS for pembro-axis, 47.2 months versus 40.8 months. And you can see the hazard ratio here has risen, has gone up from 0.84 for OS versus the primary analysis a few years ago, 0.53. So this is, something that we are seeing with the IO-TKIs over time. And here to the right side of this slide, you see the ORR in the intent to treat population. The top shaded green is blue is around 12% CR rate for the combination, and this is the PR. And then you can see here around 12% progressive disease rate. Again, that's something that we can keep in mind and discuss in our discussion here. And this is the sunitinib data. So 12% CR rate here. You have a total of objective response rate of about 60% and about 12% progressive disease rate. Now, shifting gear to this is the CheckMate 9ER. It's a cabozantinib plus nivolumab versus sunitinib. Again, similar study design to the previous trials. Here is the latest data presented at ASCO GU. And here is the Kaplan-Meier curves for PFS. And again, you see what you expect to see from an IO-TKI combination, is early separation of the curves between the two treatment arms. And you can see here landmark analysis at 2 years, 3 years, and then here at 4 years, nice separation for nivo-cabo versus sunitinib. And here you have doubling of the median PFS for nivo-cabo, 16 months versus 8.4 months. And then the hazard ratio is 0.58, nice hazard ratio for the difference between the two treatment arms with respect to PFS. Looking at OS now, again, there is an improvement in median OS over time between the two treatment arms. And then again, the curve here is, again, the theme here where the two curves are coming together. And the hazard ratio has risen here to 0.77 over time. And here are the results now. The CR rate has improved from the primary analysis with about 14% CR rate with nivo-cabo for 5 years, 55 months median follow-up. And then here response rate, around 56%. Progressive disease rate 6.5% versus sunitinib. Now, the last of the 4 regimens that came was the CLEAR study. And here is again, that was a 3-arm study, but the focus here is on pembrolizumab plus lenvatinib versus sunitinib. And this is the data, the latest data we have available with 4 years. And then here is the PFS again, nice separation as we saw with cabo-nivo and with pembro-axi. And then you can see here the medians, almost 2 years median PFS with a combination of pembro-len versus 9 months with sunitinib. And here is the hazard ratio, 0.47. Again, OS here, the curves coming together, and the hazard ratio is 0.79. So you're seeing now this trend of the hazard ratio for OS for the 3 IO-TKI regimens going up. And then here, the results, impressive, 18% CR rate for the combination, 71% ORR total. And then, here is 5%, 5.4% progressive disease rate with pembro-len versus sunitinib. Now, this is a busy slide. Just wanted to, again, for you, if you want to download this, you'll have the summary of these, not to compare them because they are different patient population that were accrued to these trials. And you can see here, the median follow-up for these here, 99 months versus 67 months versus 55 months versus 49.8 months. You can see here all the details of the median OS, the hazard ratios, and you can see that for the ITT, for intermediate risk, poor risk, and then here you're going to see the responses and the progressive disease rate down here at the bottom. Same thing here for this next slide where you summarize the 4 regimens. This is for favorable risk, and you can see here again all these important efficacy endpoints for OS, PFS responses, and progressive disease rate. And This is a summary of the safety because it's important, and we'll discuss that about, what to do because we have patients who, unfortunately develop adverse events with these regimens. So what do we do? And here is, discontinuation rate, universal treatment-related adverse events, universal for all these 4 arms. Any grade, you'll have about just all patients having some degree of AEs. When you look at grade 3 and 4, 48% had grade 3 and 4 with the nivo-ipi versus 64% in the nivo-ipi checkmate 214 trial, and here 68 versus 64 for the keynote 426, and for 9ER, 68 versus 55, and 74 versus 60 for the clear study. Discontinuation rate, about 23% discontinued nivo-ipi in the checkmate 214, and then here you see the results of discontinuation for the individual agents or the combination. And then this is important because some of these patients develop immune-mediated adverse events. There is a higher discontinuation or higher use of high-dose corticosteroids in the nivo-ipi arm here for checkmate 214 compared to the others. So I think, quality of life is important. And then each one of these trials had quality of life tools, surveys for patients to really fill out. And then, it's fair to say that the 2 regimens that had improvement in quality of life compared to sunitinib was checkmate 214 versus and the checkmate 9ER. And I think, this is something to consider when you're looking at not just efficacy, but quality of life, that the 2 regimens that showed quality of life improvement is, nivo-ipi and cabo-nivo from these 2 trials, checkmate 214 and checkmate 9ER. Now, again, coming back to management of AEs, I think it's, many of you, I'm sure, have treated those patients, and there are 2 mechanisms of action that results in AEs, whether it's a TKI, and that these are the TKIs that are attributable to TKI, the adverse events: hypertension, dysgeusia, stomatitis, dyspepsia, hand-foot skin reaction. IO, we know pneumonitis, myocarditis, myositis, adrenal crisis, and hypophysitis. Again, these are just, it's the not comprehensive list of all the AEs that could develop, but this just to tell you that there are AEs that are, related to IO. That they're IO, and you have to basically, if they develop grade 3 or 4 AE, toxicity from here, you have to stop the regimen. And then there are overlapping, and here are the overlapping ones. So determining which therapy is causing the AE is important. And then what you do in practice, you hold the AE, you hold the TKI, and then, a few days, and if the patient's diarrhea resolves, then you know that this was the TKI that caused it. Same thing, if it is, a rash or something. But if it is, something different, and you obviously have to pursue this with more investigation, and then, pursue with more diagnostic. If it's a liver toxicity, it could be both. And again, if it's nephritis, it could be both. And I think these are important to keep in mind. Here, you have this wonderful resource that you can download to really help you as a reference. Now, what I showed you are results of these 4 regimens, the doublets, what we call doublets, IO-IO or IO-TKI. But what about, following the path of, germ cell, the curable, solid tumor, and the hematological malignancies, combining, if we have different agents with different MOAs, we have, nivo-ipi, and it's IO-IO, basically anti-PD-1 and anti-CTLA-4, and we have a TKI, I think, how about combining those 3? So I'm going to show you some of these trials. So this is the Cosmic 313 that asked the question, if we add cabozantinib to nivo-ipi in patients with intermediate risk, poor risk. And so the primary endpoint of the study was PFS. This is the study design. It's cabo, the 40 milligram, not 60 milligram, 40 milligram daily dose, plus nivo 3 per kilo, and this is the induction, and then the placebo for cabo, and then the same dose scheduled for nivo-ipi. And then if patients, respond or have stable disease and no toxicity, they continue on the maintenance with cabo plus nivo, as you know, the dose schedule that you're aware of here versus placebo. Now, the primary endpoint was met. This is the PFS Kaplan-Meier plot, and you can see here separation between the 2 arms in favor of the triplet of cabo-nivo versus placebo plus nivo-ipi. However, the CR rate was low, 3% in both arms, and I think it's importantly to mention that there was toxicity in the triplet arm of cabo plus nivo-ipi. almost half the patient had liver toxicity, and that was a concern. Plus, the secondary endpoint for the study, which was OS, hasn't been met yet. We await longer follow-up to see if this will be met. Now, this is a study that Dr. Tian Zhang has been leading, and it finished accrual. This is a what we call adaptive design, where patients with intermediate risk, like the other trial, the Cosmic 3, those patients will be treated with nivo-ipi. Those who achieve a CR will continue with nivo maintenance. And that's what we do in practice. Those who have progressive disease on nivo-ipi, they come off the trial and they just take cabo. And those who do not achieve a CR do not have progressive disease, and so therefore have either stable disease or partial response. They get randomized to either what we do in practice in the real world, which is if they have stable disease or partial response, they continue with maintenance nivo, or the genius of this design is you add cabo to nivo, and to see if the addition of cabo early on in those patients who have PR or stable disease will make a difference in OS. So the primary endpoint of this trial is OS. The study accrued more than 1,000. Great leadership, Dr. Zhang, for leading this trial to the finish line. We await the results with earnest. Now, what about other triplet studies? This is the LightSpark 012. Now we have this triplet with belzutifan. I mentioned about, this is one of the latest entry to the landscape of first-line therapy for RCC. HIF2 alpha belzutifan combined with pembrolizumab plus lenvatinib versus an anti-CTLA-4 that's given every 6 weeks with pembro every 6 weeks. And this is, don't ask me to pronounce this and say it, but it's the anti-CTLA-4 from Merck that's given in combination with pembro, 400 milligram every 6 weeks, and lenvatinib again, same dose. And the control arm here in green is pembro and len at the doses that we know, 400 every 6 weeks and lenvatinib. So the two co-primary endpoints for this trial are PFS and OS in the intent to treat. Trial finished accrual. We await the results. This is a trial that's asking the question, is cytoreductive nephrectomy in today's landscape an important maneuver, an important management in our patients, okay, based on the follow-ups of the previous trials in the interferon era of cytoreductive nephrectomy and the negative trial of Carmina that showed lack of benefit for upfront nephrectomy. So this is a delayed nephrectomy. Basically, the question is patients with primary in situ and metastatic disease can be treated with your choice of a combination, a doublet, either nivo-ipi or one of those 3 IO-TKIs. Patients who progress come off. Patients who CR don't, get. But patients who have no progression and no CR, basically stable disease or PR, they get randomized to have a nephrectomy. Of course, if they have a good performance status after the treatment, and if they have, of course, resectable disease, and versus continue with therapy without nephrectomy. And so we'll await, this trial is still accruing, we'll await. This is an important question to ask now. Thoughts, and this will be my last slide here, thoughts on long-term data for these 4 key first-line regimens. Dual IO, I showed you, improved OS over 8 years. That's the longest follow-up of any phase 3 trial in first line. Potential to stop therapy, and I think I can say that we've had some patients who can achieve with nivo-ipi treatment-free survival and treatment-free interval, and I think this is the strength of giving nivo-ipi, up front. Sarcomatoid, I didn't show the data, but the results of sarcomatoid in clear cell, we published this already. 23% of patients with sarcomatoid clear cell RCC achieve a CR, 23%, and median OS 4 years. Median PFS 26 months for those patients with sarcomatoid. So there is no data that comes close for sarcomatoid than this. So for nivo-ipi, there is a consensus among us academicians that this is the treatment to give nivo-ipi for sarcomatoid. And you can say, well, what's the percentage of patients with clear cell RCC who have sarcomatoid features in their tumors? 10 to 15%. What about IO-TKI? Well, there is improved OS in intermediate risk, poor risk. There is improved OS in ITT, not in favorable risk. Not yet anyway. We'll see if with longer follow-up. I doubt that we will see that as the curves come together, as I showed you. But there is higher ORR, lower progressive disease rate, as I showed you, longer PFS, and lower immune-related AEs and lower utilization of high-dose corticosteroids. But, obviously, we have the cons here where you have overlapping toxicity. You have to worry about, which one is causing the problem. Here also the cons is you have higher immune-mediated adverse events and, lower PFS and higher PD. And I think I turn it back to you, Monty. Thank you very much.
Excellent, Dr. Tenier. Thank you. I have to tell you, when I saw your slides, there were 27 to squeeze it to 20 minutes, and I thought there's no way, absolutely no way we're going to wrap up within 20. But you did pretty good. We stayed right about on time, so thank you for that as well. So, as we always like to do during the session, we're not going to go with standard cases. We're going to try to throw out what I like to call some zingers, some tough scenarios that we all run into in the clinics and probably likely need a little bit of help managing. So I just put a very sort of brief case detail over here. 68-year-old patient, didn't specify gender here, intermediate and porous disease. I guess it's a female based on the prompts on the right there. But Tien, just based on what Dr. Tenier said, what if this was a patient with metastatic sarcomatoid renal cell carcinoma? What would your frontline approach be?
Right. I think in sarcomatoid disease, we have the best evidence of immunotherapy doublets. And so certainly one of the 4 immunotherapy doublets that Dr. Tenier just covered would be great for this patient. I will sometimes think about whether patients have symptomatic disease, but certainly Ipi-Nivo has the highest rates of complete responses, so I lean toward that. If they had very symptomatic, high tumor burden, sometimes my degree of choosing, I would look for early disease control with a VEGF-IO combination.
Very good, very good. And Dr. Tenier, maybe I'll turn to you. I know the audience is really sort of looking to sort of better understand what we do in clinical practice. So if you were faced with a patient with intermediate and porous disease, right, in your practice, let's take away the sarcomatoid features for a second, because I think you provided some really compelling evidence for Nivo-Ipi in that scenario. Which of the 3 doublets, VEGF-TKI plus IO, would you favor amongst those that are available?
I have to disclose, I have used all 4 regimens in my practice at MD Anderson. So I am a proponent of IO for the right patient, of course. And again, it's because of the durability, the CRs that are durable, sarcomatoid, histology. But I have used all 3 TKIs, IO regimens, Pembrolizumab, Cabo-Nivo, and Pembrolizumab. I think, you have to look at where are disease sites. I think if a patient has bone tropic, metastasis, significant bone metastasis, I think that is, in my opinion, compelling to use Cabo-Nivo. If the patient, even if they, it can be just bone metastasis, or it could be bone plus other organs. And I didn't, again, for the sake of time, didn't really show data that I presented at ASCO GU on, the benefits of Nivo-Ipi in different sites of metastasis. The one site that did not really do better than sunitinib was the bone metastasis. So I think this is a case where if the patient has bone metastasis only or predominantly, I might go with the Cabo-Nivo, for example, and because I think Nivo-Ipi may not produce the desired effect for that bone metastasis. I think, Len-Pem has a good CR rate and a good ORR. I mean, we saw, showed the data. It is hard to maintain somebody on a 20 milligram daily lenvatinib. And again, quality of life, this comes there. And I think, you have to go with, a Cabo-Nivo in that situation if you're looking at quality of life. But what we will discuss that in the second line. It's what we use in first line will also have an impact on what we use in the second line. If we go with a Len-Pem, for example, first line, and the patient progresses right through it or has relapse after a response, will they respond then to a regimen like Cabo or other, other TKIs? Because then you're not going to continue based on the CONTACT-3 trial, which you'll be talking about. We're not going to continue with an immune checkpoint. So I think, I have to figure out exactly not just what I'm going to do in first line, but roll out the strategy of what I'm going to do in first line, second line, third line, and beyond.
Yeah, no, well said, well said. I mean, I'll interject with just my personal preferences in this scenario, and picking amongst the 3 TKI IO regimens. I tend to favor Cabo-Nivo in that setting. I agree with you on your statements regarding bone tropism. I've struggled a little bit too with lenvatinib dosing up front, 20 milligrams. I've heard from a lot of colleagues in the community who might start at lower doses of lenvatinib, and I worry about that a little bit because I'm not sure they're necessarily getting the intended benefit if you don't start it at full dose as was intended in the studies. So, on the basis of the quality of life data that you so eloquently presented there, I tend to sort of go with Cabo-Nivo up front. And you're right, it sort of introduces a little bit of a quandary for second-line therapy, and we're going to get to that soon. In thinking through difficult scenarios that we're facing right now in the clinic, something that I think we're all going to probably see in the clinics relatively soon is that patient who's on adjuvant pembrolizumab, right, and then progresses on therapy. And I think the scenario that's pretty straightforward is the individual, for instance, who might have progression 3-4 years out from adjuvant pembro. I think that's straightforward. Maybe you treat them as a patient who's IO naive. But maybe, Tian, I'll start with you. What if the patient had progressed on pembrolizumab during the course of adjuvant therapy? Let's say they're 6 months into their adjuvant pembro, and you start seeing new lung nodules and liver mets pop up. What's going to be your go-to then?
Yeah, I think in those cases, we're thinking they're primary refractory to immunotherapy. And so there's still receptor occupancy for those T cells. They're still activated. So I will switch them to a different TKI, usually, different mechanisms. So my go-to in that certain circumstance would be usually cabozantinib as a TKI monotherapy. But sometimes, I would say that if there are, that gray zone, I think is, how far out in the post-adjuvant setting do we consider them to be potentially sensitive to rechallenge? And for Pedigree, we wrote for 1 year out from discontinuation of adjuvant immunotherapy for us to still enroll them for Pedigree. And I think usually in the correlative studies, in the early correlative studies of nivolumab, we saw T cells were activated for about 6 to 9 months. So I'm kind of in that ballpark where I would think about rechallenge with immunotherapy after discontinuation of that year of adjuvant pembrolizumab.
Got it. I mean, I tend to sort of mirror that in my clinical practice too. And if they're within that year, I tend to think of them as being IO refractory. I'll kind of go with TKI alone. Am I missing any exceptions to the rule there, Nizar, in that scenario?
I really think we have data to show that if you give Nivo-Ipi after the patient had already an anti-PD-1, they're going to have a very low response rate. The CR rate is going to be 0 to 2. ORR is going to be less than 15%. So I really don't think it would be, in my opinion, if the patient had progressive disease right through an anti-PD-1 like pembro adjuvant therapy to really go do a Nivo-Ipi in that situation. I see a lot of patients in the practice world, now they've started them on adjuvant pembro. The patient is progressing within the year while on therapy or shortly after they finish. And then the oncologist is continue with pembro and add an ACCC. I don't think it's not my practice. I do not continue with pembro if the patient is progressing through it. I would just go to TKI. Which TKI? Again, I think it would be important to look at the patient, where the sites of metastasis, the performance status. If the patient has poor risk as when they have relapse from adjuvant pembro, I would say the data is strong for Cabo in that situation because we know that based on the Meteor trial, those patients, do well. And the Cabo-Sun trial in the first line, that Cabo, it does pretty well for intermediate risk, poor risk. So if the patient has poor risk, intermediate risk, I think Cabo is a strong drug there to give in that patient instead of, for example, axitinib, if you're going to give it just a single agent TKI. The other thing is I would like to say is we published 3 years ago in the Oncologist our data from real world, MD Anderson, with lenvatinib everolimus in patients who all had prior IO, all had immune checkpoint inhibitors and had progression, and more than 80% had Cabo. And lenvatinib everolimus did produce some results that were, 24% objective response rate, median PF 7 months after Cabo. But we just also presented ASCO GU just in January, where after Len-PEM, for example, or Len plus, if you give cabo after Len-PEM, the results with cabo are not good. So I think that helps, in my opinion, how we roll out the sequencing of these agents. There is data that lenvatinib, everolimus, can produce results after cabo. Cabo after Len-PEM or Len-Ev doesn't produce the same results. So I think this has colored my selection of sequencing based on that data from our retrospective, with the limitations of retrospective studies. It is definitely a factor that I take into account. How do I roll these things out?
I think those retrospective studies are actually really quite important because, we have no way to sort of guide practice, with prospective evidence in specific scenarios such as the ones that you highlighted there. So, hats off to you for doing that. I want to sort of quickly highlight some data, but this builds on a concept that Dr. Tannir had mentioned around treatment-free intervals with nivolumab and ipilimumab, and you'd highlighted that potential benefit in the context of that particular therapy. Something that we're going to see on Monday is treatment-free intervals in the context of cabozantinib and nivolumab. This has been sort of my observation. I do have a healthy cohort of patients who have been on cabo-nivo frontline who are actually able to come off therapy. You see, some of my fellows sitting here in the audience, Hadia's right there. So we've seen a healthy number of people who have been able to roll off of TKI-IO therapy entirely and have the TFS, so to speak, the treatment-free survival that's cited here. Tian, has that been your experience as well on occasion?
Right. I mean, treatment-free survival is really time off of treatment, time without side effects for many of our patients. And so certainly we've had long-term follow-up off of Ipi-Nivo was the first analysis of treatment-free survival from the Farber group. And, I think with the Cabo-Nivo data, we'll see some patients can be off treatment and hopefully without side effects and really be living their lives, right? We didn't ever continue high-dose IL-2, for example, indefinitely. And so for a certain number of these patients, they can have really durable responses. So I think that's the holy grail, if you will, for metastatic disease is to come off treatment and still have durable responses.
Yeah, it's so hard to know when to pull the trigger and stop therapy, right? Under these circumstances, it's a really important decision that has to sort of take into account detailed perspectives from the patient. But, when it happens and it works, it really can be a beautiful thing, I would say. We're going to wrap up this first section here by discussing combination therapies and understanding the patient's viewpoint. I think the bottom line from this really important data set from KC Cure is that, it's really critical that we start to infer our patients' perspectives on toxicity very early in the course of treatment. So, as you can see reflected here, there is a desire from patients on many occasions to exert a dose reduction, modification of dose, and we need to be sensitive to that as opposed to maybe making that decision ourselves as practitioners. So with that, we're going to close our first section and move on to refractory metastatic kidney cancer with Dr. Zhang.
Wonderful. Thanks, Monty. Let's move on. So in the theme of KC Cure surveys, this was a very important one of over 1,000 patients that KC Cure had done, over 300 of whom almost 400 with metastatic disease, and thinking about what patients prioritize and expect from their systemic therapy in metastatic disease. And predominantly, you'll see that the chance of a complete response, the chance of a cure is highly valued, and the durability of response, so what we were just talking about, is sort of second right there, along with improved quality of life, rapid reduction of tumors, and then the ability to go off therapy, which we were just talking about for treatment-free survival intervals. So patients are really hoping for a cure. They're not so much familiar or concerned with their risk stratification, but they, if we present data to them of these are therapies that might help you achieve a complete response, if that's what you value, then that's what they're helping us in our clinics with the shared decision making. Really, our patients are driving those decisions. So very important survey data from our very own patients. So in thinking about refractory metastatic renal cell carcinoma, we're really thinking about what patients have received in the frontline setting and then what are their options. Dr. Tenier touched a little bit on this earlier. And so in the frontline therapy setting, when we're giving ipi-nivo immunotherapy combinations up front, then we're often thinking about VEGF-TKI monotherapy given the CONTACT-3 results. If we're giving VEGF IO combinations, we're often giving an alternative VEGF TKI strategy. And then if we're going into TKI monotherapy upfront, then we're often switching them over to nivolumab monotherapy or an alternative VEGF TKI. So certainly dependent on the frontline treatment and also the timing of resistance. We're showing here in this table second line and beyond trials that have already been done for kidney cancer management. AXIS trial was axitinib versus sorafenib done many years ago. Meteor trial, you heard Dr. Tenier just refer to, cabozantinib versus everolimus, also completed almost 10 years ago now. Checkmate 025 of nivolumab versus everolimus, also the registrational trial that gained nivolumab its label. The ones you see highlighted in red are the ones that we'll talk about. So randomized phase 3 TiVo-3, tivozanib versus sorafenib, non-randomized phase 2 CABOPOINT of cabozantinib alone in different cohorts, and then also the randomized phase 3 LIGHTSPARK-005, which was the registrational trial for belzutifan. In the combination treatments in the second line and beyond, there was a Keynote 146 trial that was non-randomized. This was a cohort that we'll show you of lenvatinib and pembrolizumab in the refractory setting. The non-randomized phase 1b and phase 2 T-Nivo of tivozanib with nivolumab, and then phase 3 CONTACT-03, which was just read out about a year and a half ago. And then finally, LIGHTSPARK-003, non-randomized trial of belzutifan with cabozantinib combination. There are two trials that are awaiting results, one of which is tivozanib with nivolumab, T-Nivo-2. This trial is fully enrolled. We're highly anticipating results from that, hopefully later this year. And then the phase 3 LIGHTSPARK-011, this is the combination of belzutifan versus belzutifan with lenvatinib versus cabozantinib, also awaiting results. Oh, all right, so we'll get started here. This is the phase 2 CABOPOINT trial of pure second-line cabozantinib with two cohorts. Cohort A were patients who had disease progression after dual IO therapy, so ipilimumab, nivolumab, and cohort B were patients who had disease progression after IO TKI combinations, and everybody was treated with cabozantinib 60 milligrams daily with a primary endpoint of objective response rates. You see that those objective response rates on the right side here, right around 30% objective responses, in particular all partial responses except for the patients in cohort B. There were about 4% complete responses. So this study was done by our good friend Dr. Albachez and a French cohort of patients, but showing good activity of cabozantinib in post-IO treated patients. This is the next phase 3 trial of tivozanib, TiVo-3. This is the registrational trial of tivozanib that was done. Tivozanib being a selective and potent TKI inhibiting VEGF receptors 1, 2, and 3, has a pretty long half-life. And based on this trial of tivozanib versus sorafenib, showing an improvement in progression-free survival, hazard ratio here was 0.62. The FDA approved tivozanib for patients with relapsed or refractory advanced renal cell carcinoma. And importantly, these patients are clinically relevant portion are still alive and progression-free at 3 years and 4 years after starting on this trial. So this is a nice option for us in the advanced settings, in the refractory setting. This is the conditional overall survival in patients who already achieved a 12-month progression-free survival. You'll see here hazard ratio of 0.45 for patients treated with tivozanib versus for sorafenib. So as we have extended follow-up of survival, we're seeing that hazard ratio improve as we see events mature. So certainly there's some good effect of tivozanib even later on in the disease course as we're sort of following these patients longer on the TiVo-3 trial. And then finally, these are side effects of TiVo-3. You see what we usually expect in patients treated with VEGF TKI, so hypertension, asthenia, fatigue, diarrhea, hand-foot syndrome, some nausea, and some rashes, although these are at much lower rates than for patients treated with sorafenib. All right, so what about a combination approach? This is Keynote 146, a non-randomized cohort of patients treated with lenvatinib plus pembrolizumab, led out of Memorial Sloan Kettering from our friend Dr. Joe Lee when he was at Memorial. These are all patients with metastatic renal cell carcinoma with a clear cell component and measurable disease who had progressed past prior IO therapies. They're all treated with lenvatinib and pembrolizumab with a primary endpoint of objective responses. And so you'll see the waterfall plot here. The ones in green are treatment naive. So there was a cohort that were not refractory. The cohort in red there are patients who were treated previously with immunotherapy checkpoint inhibitors. And then the expansion cohort, which was the majority of the trial, 101 patients were previously treated with immune checkpoint inhibitors. And you see a good amount of patients with disease stability or better, and many of whom achieved partial responses. So good activity of lenvatinib plus pembrolizumab even after prior immunotherapy combinations. Based on many of those trials, the phase 3 CONTACT-03 was designed. It also stemmed out of a basket trial called COSMIC-021, which Dr. Powell led. And this was a trial of combination cabozantinib, atezolizumab in patients who had progressed on prior immunotherapy containing regimens. So atezolizumab and cabozantinib was the experimental cohort versus randomized to the control cohort of cabozantinib alone at 60 milligrams daily. This is the overall survival that was presented now almost a year and a half ago, and you see no difference in the cohorts treated with cabo versus atezolizumab with cabozantinib. So progression-free survival median was 10.6 months versus 10.8 months. No difference there. Median overall survival right around 25 months. Again, also hazard ratio 0.9. No difference between the two cohorts. So what other data do we have about combinations? The phase 1/2 T-Nivo trial, tivozanib plus nivolumab, follow-up of 19 months. You see here the previously treated cohorts in blue. Median progression-free survival was actually not reached. Treatment-naive patients had a median progression-free survival of about 19 months. And you see here objective response rates of about 50% of the 12 patients who were treatment naive and about 62% in the patients that were previously treated. So certainly the small sample size limits our interpretation of this in general populations, and therefore that sets up the T-Nivo-2 trial, which is a phase 3 trial of tivozanib with nivolumab compared against tivozanib alone with a primary endpoint of progression-free survival. This trial is fully enrolled, and we're looking forward to the data coming out hopefully later this year. All right, switching gears just a little bit and thinking about the HIF pathway. So we learned a lot about clear cell kidney cancers from Nobel Prize winning work from Bill Kalin, Greg Semenza, Peter Aculiffe. And in that understanding of hypoxia, we also understood just how important the HIF molecule was in downstream signaling and increasing the tumorigenic effects of things like VEGF, EPO, TGF-beta, and therefore inducing the tumor progression that we see for clear cell kidney cancer. It was for a long time thought that the HIF complex was not targetable because it's a transcription factor. And indeed, through careful work done actually at UT Southwestern, my home institution, there was a small molecule screen that was performed and a molecule that came out. The Peloton molecules, PT2385 was the first one in human, which basically clogged up the dimerization of HIF-2 alpha with HIF-1, and therefore did not allow the dimerization of the HIF complex and the downstream translocation into the nucleus and transcription. Through structure-based drug discovery, the UT's Southwestern lead molecule then got converted with a couple of fluoride molecules there to then the PT2385 phase 1 study that was initially done, led by Dr. Courtney at our institution, and then the PT2977 molecule that you see the 2 fluorides got moved a little bit. Brilliant chemists to the belzutifan molecule there, which is now approved for HIF-2 alpha inhibition. And you see there some of the bioavailability studies. So belzutifan had better bioavailability and was therefore the winning molecule that went further into clinical development into phase 3 trials. So this is the phase 3 LightSpark 005 trial, the registrational trial for belzutifan in patients with metastatic clear cell kidney cancer that were previously treated with less than 3 lines of prior treatments, randomized to belzutifan versus everolimus, with a primary endpoint of both progression-free survival as well as overall survival. You see the progression-free survival here on the top curve, and then also overall survival on the bottom curve. There is some crossover in the progression-free survival curves. If you look, the hazard ratio after 2-year follow-up was 0.74, favoring belzutifan, but there's some early drop-offs in that belzutifan-treated patients. And for that reason, it's really important for us to think about which patients are the good candidates, if you will, for treatment with belzutifan, because the responders will actually respond a very long time, and they actually drive that difference that we see in the longer-term follow-up. Overall survival, not enough events and not mature yet, so the trial has not matured for overall survival, but belzutifan was approved by the U.S. FDA for treatment in metastatic refractory renal cell carcinoma. And of note, the objective response rate seen with belzutifan was 22%, certainly higher than that seen with everolimus. All right. If belzutifan is good on its own, it's well tolerated. How about the combination? So belzutifan and cabozantinib has been evaluated as a combination in cohort 2 of LightSpark 003. This is previously treated patients treated now with a combination of belzutifan and cabozantinib. Objective response rate of 31%, and this is a swimmer's plot. You see many of these patients with blue arrows continue on treatment during that follow-up and certainly benefiting from the combination approach. The phase 3 LightSpark 011 has now been completed in terms of enrollment. It is patients with metastatic advanced refractory disease who have received 2 or fewer prior lines of therapy, treated with a combination of belzutifan and lenvatinib compared with cabozantinib. The primary endpoint here are progression-free survival and overall survival. And again, a highly anticipated combination and trial for which we hopefully will see in the next year or 2. All right, so some key takeaways in the refractory setting. As more treatments are now available in the earlier metastatic renal cell carcinoma lines, the treatment selected in refractory disease has become challenging, and it depends on what patients received previously in the frontline setting as well as timing of progression. Tivozanib is the only VEGF TKI that's been developed now in the post-immunotherapy era, having disease activity when compared against sorafenib from TiVo-3. Belzutifan presents a really nice new mechanism of action targeting HIF-2 alpha in the refractory setting, and lenvatinib and pembrolizumab still has some efficacy in that non-randomized trial that we looked at as an IO-TKI combination in the refractory setting. And the ongoing trials that we presented, both TiNivo-2 as well as Pedigree, will give us further data to think about treatment sequencing. And I would just add one more, which is as we learn more about disease progression and resistance mechanisms in the refractory setting, we will need to do very careful correlative studies to really drill down on those mechanisms to design rational trials in the refractory renal cell carcinoma setting. And with that, I will turn it back to Dr. Powell.
Wow, Tian, 4 minutes early. Outstanding. Well done. Well done. No, that was a really excellent overview. And it's actually a perfect segue into this case that we want to sort of build on. So, let's imagine this particular patient receives frontline therapy with, let's say, cabozantinib and nivolumab. I'd mentioned that I use that in the majority of my patients frontline. If that patient progresses, perhaps in the manner that you see here with liver metastases and lung metastases, my experience with belzutifan, to be frank, has been a little underwhelming in the salvage setting. The challenge for me is that, there's sort of a long time to response. And I think that oftentimes when you see that patient progressing beyond frontline therapy, it's really hard to predict the kinetics of progression. So using belzutifan becomes a little bit dicey. And actually, Tian, you did a nice job of sort of articulating that in the Kaplan-Meier curves from LIGHTSPARK 05. So I tend to use for the patient with really aggressive progression, say on cabo-nivo, lenvatinib and everolimus. But I will say that I've had a lot of success in prescribing and getting for my patients tivozanib in that setting, and I've been very pleased with the activity. So, I will say for the patient who has disease that's migrating through multiple organ sites, let's say liver, lung, bone simultaneously, and if they can tolerate a tougher regimen like lenvatinib and everolimus, I'll probably go to that as my second line. But for many patients, probably the vast majority, I would say, they're going from cabo-nivo to tivozanib as the second line strategy. And then belzutifan, just as you said, Nizar, is kind of coming later in the sequence for me.
If I may add, Monty, I'm impressed with how tolerable tivozanib is as a single agent, despite the fact that it has the longest half-life among all the TKIs, 120 hours. And, obviously the one that has the shortest is axitinib, 4 to 6. And then, lenvatinib is around 46 hours. And then the one, cabo has a 99 hours, half-life. But tivo, long half-life, the longest half-life among the TKIs, yet very tolerable. I think if you, know how to dose it and follow the patient, you can treat those. It doesn't cause the hand-foot skin reaction, the mucositis, etc. It's just hypertension, some fatigue and some diarrhea, but very little, off target. The mucositis and hand-foot skin, very little of that. Very little myelosuppression either. So I think it's a good therapy and it's very tolerable to really give. So
see the way that Dr. Tenier just rattled off those half-lives, that tells you he has a photographic memory. I'm always impressed at how he's able to cite and quote the data, no doubt about it. Tian, maybe take us through your third line decision making. Let's say this patient did get cabo-nivo up front. Let's say then they went on to maybe tivozanib by the algorithm that we've just discussed. What are you thinking about in the third line setting for that patient?
Right. And, for me, I try to draw out as long as possible. So thinking if they're oligo progression, I'll start to think outside the box and think about radiation, for example. If they're really progressing in multiple organs and we're convinced that they're refractory to their current treatments, we'll be switching. And so I agree with Dr. Tenier. We're thinking about lenvatinib and everolimus in that setting. We're also thinking about belzutifan in that setting. And it kind of depends on how they've responded to their prior treatments. If they've had a really long course on cabo-nivo, for example, and on tivozanib, then maybe they are truly angiogenically driven, and those are the people who we might give belzutifan a shot. If they're sort of blowing right through each of these regimens, then I worry that they're not so angiogenically driven. But, there are responders to belzutifan that are surprising, and so I would love to see some more biomarkers of patients who respond to belzutifan to find the right patients for belzutifan treatment, and certainly be thinking about that as a potential option in that third line setting.
So it's interesting. You said angiogenically driven, and I think that hits on one of the major themes from ASCO this year, which is the use of genomic profiling in the context of large phase 3 clinical trials. I think on Monday we're going to hear a lot about angiogenic signatures and immunogenic signatures and so forth. I wanted to kind of get your perspective. And of course, here we're speaking to, a very large audience of folks who are there, boots on the ground, treating patients with kidney cancer. Can you kind of give us a sense of what the role of genomic profiling is in your practice?
Sure. So I'm a big advocate for genomic profiling in general, especially when we have treatment options that target the particular pathways. In kidney cancer, it's been a little bit dicey, but we are learning more and more about genomic, thinking about certain genomic alterations that play into prognosis, for example, like VHL loss, like BAP1 loss, like PBRM1 loss. So those can be more prognostic for us, not directly predictive in terms of treatment selection so far, but I would love to hear how you're using genomic testing for kidney cancers in your practice.
I do it pretty pervasively. I think there's some alterations that you come up with on somatic profiling, like alterations in the TOR pathway that might steer you in one direction. I certainly use it in non-clear cell patients, without a doubt, just to highlight any molecular alterations. Now, many of our non-clear cell designations will touch on this a little bit, really lend themselves to molecular alterations. We're actually looking for ALK. We're looking for, TSC1, 2, BAP1, et cetera, to define some of these. Nizar, maybe I can throw the same question at you. You obviously, your center is known for their work in genomic profiling in this disease.
I do not, obviously we do them routinely on most patients, but I don't think it will impact my decision in first line. So in first line, I'm going to choose one of those 4 regimens, depending on the scenario, the host factor and the disease sites, etc. But obviously, as patients, because we know once the patient progresses through an immune checkpoint-based regimen, we're talking now then, there is unfortunately less, we're not talking about curative or durable responses. We're talking about palliative, and we're talking about, okay, what agents, what therapies am I going to line up for second line, third line? Because they're not going to have a durable response for a long time with a TKI or, a HIF2 alpha inhibitor. So this is where I really think the NGS could help detect some actionable genes or pathways that we can have a phase 1 regimen for those patients. So yes, in the salvage setting, we use that. And of course, as you mentioned, in the patient with variant histology, where, the immune checkpoint-based therapies is not as effective as in clear cell. So I think obviously RMC, collectin duct, translocation, even papillary, which is the second most common RCC type after clear cell. Even in those, I think, after they progress through a first line, those patients need some, therapies lined up for them. And I think this is where genomic, would definitely, hopefully help identify something for them that's actionable.
And I do see one question coming through the audience on translocation renal cell carcinoma. I promise we're going to get to that after the next section, but we're going to wrap up this section with a question that I think is actually a really valid one from an audience member who asks, in that patient, again, let's use the scenario of Cabo-Nivo up front. Let's say they get past 2 years, you drop the immunotherapy after 2 years, as was done in the protocol in Checkmate 9ER. Let's say they progress after a span of a year and a half or 2 years thereafter. In that scenario, would it be reasonable to re-challenge with IO? What do you think, Tian?
If they're progressing, 6 to 9 months after, and we're really convinced that, they've had immunotherapy benefit up front, I might think about re-challenge. There's that, the lenvatinib and pembrolizumab data in the refractory setting. So I'm always a proponent of more choices and thinking through. And so if they had a good response up front and now, slowly progressing 6 to 9 months after stopping nivolumab, I think it is a reasonable option to consider another IO therapy.
Yeah, I kind of like the fact that you brought up the same conversation I'm having around adjuvant IO, right? Because I think some of the timelines still potentially apply in this context as well. So I think that's very reasonable. I'm going to move on to the next section just in the interest of time. And we're going to talk about some ongoing innovations in kidney cancer. Let's talk first about this potential prospect that we have of using subcutaneous IO therapy. So, we all know that IV infusions have their issues. It really tethers the patient to the infusion chair for a long period of time. There's staffing issues that surround it as well, right? So subcutaneous approaches certainly do have potential benefit. I would suggest that you can see the benefits noted here, might alleviate the need for ports, might allow for more flexibility in dosing. I talked to a couple of colleagues from low middle income countries who state that, there's tremendous burden on infusion centers, so having a subcutaneous option really is of a particular advantage there. And there's a number of phase 3 clinical trials that are looking at subcutaneous IO to address this. And it goes beyond the data for nivolumab that we're going to be discussing today. There's subcutaneous nivolumab with relatlimab, sasanlimab, atezolizumab, and so on. And the study that we're going to focus on, with this being a kidney cancer forum, is the Checkmate 67T study. And this looks at subcutaneous nivolumab versus intravenous nivolumab. And this is in a population of patients with clear cell renal cell carcinoma who are IO naive. Now, this study was done in parts of the world where there might not have been frontline access to IO. So keep that in mind as we look through this data. But what I thought was really, just consistent with what we'd expect here is that the administration time was far shorter with subcutaneous therapy, 4.7 minutes versus 30.9 minutes for the infusion on average. And if we look to the clinical data for this, again, response rate was a secondary endpoint in this study, so take that with a grain of salt. Really wasn't powered to look at this. I certainly don't think we can say that subcutaneous therapy looks any worse. Response rate was 60% versus 45% with intravenous therapy, PFS 7.5 months versus 5.5 months. And so there's some really great data. I stopped by a poster that My Table Alone was presenting at today's sessions, which I thought was, really did a great job of articulating this principle. That's the one on the left. Sabby George also did some health-related quality of life studies that are highlighted on the right here. Well, let's just take a moment and stew over this. So, maybe Nizar, I'll start with you. When do you potentially see yourself using subcutaneous nivolumab in renal cell carcinoma? There's a couple scenarios listed here. Just to differentiate for the audience, would you use it with ipi-nivo, where, for instance, the patient still might be getting intravenous ipi? Would you use it in the context of cabo-nivo or other TKI-IO regimens prospectively? What are your thoughts there?
If I'm going to be using nivo-ipi induction, I think probably I will wait until they go through that induction, and later on when they're in the maintenance phase of nivo, you might do the sub-Q nivo instead of the IV. I agree with you. At MD Anderson, as well as I'm sure at many academic centers, and especially not just in the US, but in the rest of the world. I mean, in Europe, I was talking to some colleagues in Europe. They are really, pressing for, they need to decompress the clinic and the infusion center. So it's really crowded and there's no room. I mean, sometimes we have to schedule patients, they cannot get it, and maybe they go locally or come back 2 weeks instead of. So I think this is where a sub-Q would definitely decompress the clinic and infusion centers, and it would be. But as you just showed, it is a 5-minute, so I don't think the patient is going to give it to themselves, if it's a 5-minute sub-Q. I know that there are some other drugs, cancer drugs where patients are sent home. We used to send them home with interferon sub-Q, and they did it to themselves. So I do think it's going to come down to cost. And definitely convenience is going to win sub-Q over IV. But the cost, if the cost of the sub-Q is much, much higher than the infusion, than the IV nivo, I think there will be pressure on using the IV because the cost of sub-Q, and especially if the IV nivo becomes, available as a generic. And I think so. Cost is going to, I think, determine how we're going to be. If it's going to be on formulary at the hospital, if insurance carriers are going to approve it. So I think cost, we have to see what the cost is going to be.
And I think you're spot on with that as usual. I mean, I think that, I hadn't even considered the perspective of maybe using nivo-ipi infusion up front and making the transition over to subcutaneous, but that actually makes a lot of sense to me for the maintenance phase. I really like that idea. I'm guessing with TKI plus IO, you can just right out the gate start with sub-Q perhaps and spare the patient any time, in the infusion clinic per se. And Tian, this is an interesting one. So, we started using nivolumab as salvage therapy in bladder cancer, right? We also use nivolumab now as adjuvant therapy in bladder cancer in certain instances. I mean, do you think that the data that we're seeing so far might potentially push the reach of subcutaneous nivolumab outside of just kidney cancer?
I think if the label expands for subcutaneous nivolumab, and certainly could be applied in other disease settings where we use IV nivolumab, and certainly in the adjuvant bladder space, many of us also treat bladder cancer in our clinics, and so the high risk, likely to relapse and have disease recurrence, have access now to adjuvant nivolumab, and I think those are good patients to consider, subcutaneous nivolumab because it's fast, it's easy, chair time is minimal, and hopefully that helps the patient navigate that adjuvant process. And hopefully, we saw some good efficacy data and good receptor occupancy, and so I don't see, obviously it hasn't been compared head to head to IV, but I do see some good disease activity. It might help the convenience factor of getting a patient through adjuvant treatment.
Yeah, well said. Well said. I completely agree with you there. And regarding what the care team needs to keep in mind, I mean, maybe just a little bit of an editorial plug here. I mean, I do think that the infusion time, the 30 minutes that my patients spend getting their intravenous nivolumab can oftentimes be a really engaging experience with the nursing team. At my institution, I'm sure at yours as well, I mean, we've got incredibly thoughtful nurses who really sort of spend a lot of time interrogating side effects and better understanding the patient's experience, and oftentimes give us good feedback regarding symptomatology that we might not necessarily be privy to during a clinic visit. I would just suggest that we still need to sort of encourage that relationship moving forward. I think that's going to be really critical. And we're going to wrap up with, I think, what's going to be a really exciting session that talks about what's sort of new and upcoming in renal cell carcinoma. And this is an agent that I think is going to have, in my opinion, a very promising future in renal cell. This is zanzalintinib. But at the outset, it actually looks very similar to cabozantinib in certain ways. You look at the targets of zanzalintinib, it hits MET, it hits AXL, it hits another target called MER. Just as cabozantinib does, it has some unique immunomodulatory properties as well. There's some interesting and emerging data around distribution of the agent that I think is going to really sort of have an impact around, how the drug manifests and works and differentiates itself from cabozantinib. And we're going to go over some of the trials highlighted at the bottom right in just a moment here. I'm going to focus on the Stellar 001 trial, which is something that me and others here have participated in. This started as a dose escalation experience in about 12 patients, and then we quickly migrated into a clear cell renal cell carcinoma expansion cohort. We have a safety population that encompasses 81 patients in total, and we ultimately arrived at a dose of zanzalintinib of 100 milligrams daily. Now, I want you to bear a couple of things in mind as we look at the clear cell renal cell carcinoma cohort. This included 32 patients. This was a patient population that had very aggressive disease characteristics. So 38% of patients here had liver metastases, 34% had bone metastases. If we look at the extent of prior therapy, you see that 41% had 3 or more prior lines of treatment. And this is really interesting, and this is an important element of the data set that I want to focus on. About half of patients here receiving zanzalintinib had actually gotten prior cabozantinib. So again, it's questionable as to what the response might be in that context, given the similarities of drug target. But what we saw, in my mind, was pretty remarkable. Response rate was 38%. This, in my mind, is a really encouraging waterfall plot here. Disease control in the vast majority of patients. And what's really striking is that if you look at the subset of patients that had received prior cabozantinib, again, that's half of the patients in the experience, 24% or a quarter of them actually had a response to therapy, and in total, 94% had disease control, which, again, I thought was quite striking. If you look at the subset of patients who did not receive prior cabozantinib, you can see that the response rate was significantly higher, 57%. So again, quite impressive on the whole. There was a small smidgen of patients that had just received prior VEGF DKI, and in that context, you can see the response rates noted on the right-hand side there. Again, impressive amongst those patients that had not received cabozantinib as well. We did a little update here at ASCO 2024 regarding biomarkers paired with this study. In my mind, the biomarker changes that we're seeing here are perhaps somewhat anticipated. They'll focus, for instance, in the top left on HGF, which is the ligand for MET. And what we see in the context of that data set is that, with MET levels are high, we see that that tends to be enriched in the context of patients with stable disease and progressive disease. HGF levels are low. We're seeing more in the way of partial responses and CRs. There's a number of studies that are rolling out evaluating zanzalintinib. We have studies looking at zanzalintinib plus nivolumab, zanza-nivo and IPI, and zanza-nivo and relatlimab in the context of the STELLAR-002 trial. There's a second cohort looking at the same combinations in the context of second-line therapy. And there's actually a non-clear cell cohort as well. And I think this is going to be a really important experience moving forward. As many of you know, one of my areas of interest, Nizar and Tian are also doing great work in this space, is non-clear cell kidney cancer. And this comprises about a quarter of cases. This is actually a beautiful diagram that comes from a review article that my colleagues at MD Anderson put together in clinical genitourinary cancer. I actually really like the figure at the bottom there that very quickly highlights the demography of the disease, relevant mutations. I stole this for a lot of my slides, actually. Who is that, by the way, Nizar, the first author?
It was a Greek resident.
Oh, yeah.
Working with us, with Pavlos and I.
Oh, no kidding. Really, really great work in this review. So I'm not going to belabor the nature of non-clear cell, but I think that this figure really nicely articulates the fact that it's a very heterogeneous disease. You can see that there's multiple genomic drivers, big distinctions in terms of the demography, as I highlighted earlier. And we do have a trial that I think really uniquely addresses this population and several subsets of this. The Stellar 304 trial is a study that includes patients with papillary, unclassified, and translocation renal cell carcinoma. Noted a question from the audience on translocation RCC. I think it's really imperative that we better understand which therapies drive the disease. So this trial randomized to zanzalintinib plus nivolumab versus sunitinib. Enrollment's well underway, and we certainly encourage you to reach out. We've got it running at our center if you have patients that might potentially be candidates for this. We have a trials in progress around this study here. What about combination therapy in non-clear cell kidney cancer? This is compelling data. I have actually teased out, just for sake of comparison, the response rates in papillary disease embedded in each one of these combinations. So, just from memory here, with cabozantinib and atezolizumab, response rate is 47% in patients with papillary disease. With cabozantinib and nivolumab, it's 47% as well. There was just an update in European Urology published this week on that particular data set. Bevacizumab and atezolizumab, response rate is 23%. So what you might expect. I mean, we didn't see, as perhaps compelling data for Bev-Atezo in the context of clear cell RCC. And finally, with lenvatinib and pembrolizumab, response rate of 53% in papillary renal cell carcinoma. I would suggest that there's compelling data here, but these are single-arm data sets. In some cases, for instance, with Cabo-Nivo, they largely reflect, for instance, single institution experiences. So I think we have to kind of take this with a grain of salt. I do want to mention that Charles Wynn, who is a brilliant fellow who's actually come into City of Hope, we're very proud to say, he's now at the University of Michigan, is presenting a trials in progress for tivozanib and nivolumab in the context of non-clear cell RCC. And I think that's going to be an important addition to this slide here in a couple of years. And I wanted to wrap up with what is really quickly becoming one of my favorite topics in renal cell carcinoma, which is the gut microbiome. So for a long time, we've seen really compelling data in the context of melanoma, lung cancer, a smidgen of data in renal cells suggesting that the gut profile may potentially drive responses to immunotherapy. So our group's taken a preliminary stab at trying to see whether or not we could potentially manipulate the microbiome to enhance response. One of my superstar fellows who's now training under Nizar at MD Anderson, Nazli Disman, published the first data set that you see there in Nature Medicine, looking at nivolumab and ipilimumab, plus or minus CBM-588. And you can see that there seems to be a compelling improvement in progression-free survival, albeit with the caveat of these being very small data sets. Following up that great work is my fellow who's sitting in the front row here, Dr. Hediye Ibrahimi, who hails from Iran and is spending 2 to 3 years with us at City of Hope. She's published a really, she is about to publish, I can't say where, but it's a great journal, really great journal, the data for Cabo-Nivo plus or minus CBM-588. And I would say equally compelling in some respects. So with this information, we're actually moving forward with a SWOG proposal looking at immuno-oncology therapy plus or minus CBM-588 in the context of a phase 3 trial. So Pedro Barata, a dear friend of all of ours, is going to be the PI on that study moving forward in SWOG. This is another passion project of ours at City of Hope. Anybody, just by show of hands here, know what camu is? It's a South American fruit, and it actually seems to really sort of propagate the immune response in preclinical models. So, it's been looked at in the context of melanoma cell lines and murine models, and you can actually see in those models that camu and its relevant extracts can actually lead to synergy with PD-1 inhibition. So we have a trial ongoing right now led by a fellow of mine from Mexico City looking at nivo-ipi plus or minus camu. I would say pretty encouraging data so far emerging from that. Yeah.
It tastes great and it's not filling.
Amazing.
That's a good one. We do have to see if we can make a nice smoothie out of it. I think that would actually be a great suggestion. And then beyond that stuff, beyond the microbiome-based stuff, which I'm super enthusiastic about, are some collaborations that the three of us and others here in the room are working on together. What's really interesting is we're trying to bring modalities like CAR T-cell therapy and ADC therapy to renal cell. I had the pleasure of working with the compound on the left, the CTX130, which is a CAR T directed at CD70, a very pervasive renal cell antigen. We just published this in Cancer Discovery a month or two ago. And I'm not going to say the data was groundbreaking in this case, but we did see a signal of activity. Most patients had stabilization of disease. One had a complete response that was quite durable. So I'm really eager to kind of see if we can build on this with subsequent CAR T trials. And we have several at our institution. I know Nizar has many running as well for renal cell at MD Anderson. I collaborate a lot with him and other colleagues there on this body of work. ADC therapy is also something that's coming to renal cell that I'm excited about. ENPP3, a target I had never heard of prior to hearing about this particular study, is a pervasive antigen in renal cell. And we have a bispecific therapy. Again, this is a study Nizar and I and others at MD Anderson and City of Hope are working on. So bispecifics may be coming to the disease. And finally, at this meeting, I presented some data from what I'm going to call an incomplete trial of a drug called DFF332. This is a novel HIF-2 alpha inhibitor. Works in a manner very similar, I would say, to belzutifan mechanistically, but very limited toxicity. Activity, very modest, I would say, and perhaps the lack of activity, the very minimal toxicity is because we just didn't get to the right dose level. So Nizar and I chaired the study together, and we're hoping, or I really do hope that we find somebody to sort of take the reins on this one and build this compound further. So that concludes our slides, and I was going to actually just jump into some audience Q&A that we have. First of all, I wanted to sort of address a question that's come up in the chat a couple of times now around translocation RCC. Nizar, I always kind of look to you for advice on some of these rare histologies. What right now is the MD Anderson approach to translocation RCC?
Good question. And this is where we really need to have, modern, comprehensive, in-depth molecular characterization of these, because translocation RCC is not one disease. It's not. So we know that every tumor has heterogeneity, even if it's the same histology. But translocation, there are, different translocations, different partners, different fusion proteins with TFE3 and so many different partners. And each one of them may have a different biology and different therapeutic response. So I think our experience, we published that in the Oncologist, last year. It seems like the immune checkpoint inhibitors, whether it's nivo-ipi or IOTKI, do not. Again, we had 29 patients, all confirmed by FISH, that were translocation. The nivo-ipi data, we had 1 PR out of 18. That's 5% response rate. Median OS 13 months. We had 11 patients treated with IOTKI, different regimens, different IOTKIs. Response rate was 4 out of 11, small numbers. But OS was similar, 13 months. So we really have our work cut out to do. I just don't think the translocation RCC patients are going to respond as well as clear cell or papillary to immune checkpoint based. So Cabo is the drug that we use. We published on that the year prior to that from a international collaboration of several European countries and US sites, and where we showed some promising activity for Cabo single agent. So Would I give Cabo-Nivo? I mean, I think obviously if there is no contraindication to give Nivo, I would, Nivo-Cabo for those patients. But I really am not really sold on the immune checkpoint inhibitors in this tough to treat translocation. This is where we really need some new therapies and deep dive into molecular characterization.
Yeah, that's beautifully said. I thought a lot about this question because I'm giving a talk on Monday around non-clear cell kidney cancer. I actually cite your wonderful paper with Omar Al-Halabi and the oncologist, and it gives a really nice sort of perspective on the contribution of IO, I think, and perhaps the questions around it. Question from the audience is, do you think that zanzalintinib is going to make its way into the clinics for translocation RCC? I think what we really need to do as a community is get behind trials like this. And for translocation RCC, or ostensibly, as Nazar said, we don't have an obvious standard. I think a trial like Stellar 304 could potentially help address that question. Last question of the night goes to my friend, Dr. Zhang, chromophobe renal cell carcinoma. It's a challenging one to treat, just like translocation RCC. My practice has been, if you don't mind me sharing, that I think that lenvatinib-based regimens seem to have some special activity in this context. So I know basing this on very small data sets, but we've got Tom Hudson's data for Len-Ev with 4 out of 9 patients responding. We have data from Laurent seeming to suggest activity, modest, but still some activity with Len-Pembro in the context of chromophobe RCC. What are your thoughts there?
Yeah, well, even dating before that, Dr. Neer had the early ESPN and then later on Andy Armstrong at Duke Aspen studies, and there were subsets of chromophobe in those populations where everolimus had some effect of chromophobe disease. So I think an everolimus-based treatment, and if they're in reasonable, physical health, very not frail, lenvatinib with everolimus might be a very nice combination to try. We've also seen just a few not such great results of immunotherapy-based combinations for chromophobe, but sometimes stability of disease, not quite objective responses. So, for example, we had the triplet trial, Cabo at Nivo from Brad McGregor and the Farber Shop Open, and not such a slam dunk histology in terms of triple therapy. So I'm quite cautious on immunotherapy for these folks, and I like more the lenvatinib and everolimus approaches.
Well said. Well said. Well, what a great way to sort of conclude the evening. I think we've got a lot of very challenging questions answered over the course of the night tonight. Thank you all for staying with us, and hope to see you here again at the next meeting. Thank you.
Thank you for listening. Remember to download the slides and practice aids and complete the post-test for instant credit. This activity is certified by PVI, PeerView Institute for Medical Education. This activity is developed with our educational partner, the Kidney Cancer Research Alliance. This educational activity is supported through medical education grants from AVEO Pharmaceuticals Incorporated, Bristol Myers Squibb, and Exelixis Incorporated. To access all materials for this activity, visit peerview.com/GXM860.